Okay. Share my screen. Get back into it. Okay. Oh, go back. Oh, go away. I want you. Thank you. All right. So back to pressure dressings. Okay. Place several gauze pads on the wound. Hold the dressing in place with a self-adhering roller bandage, like an ace bandage, or you can use something that you see down here. This is actually an Israeli bandage. I know Charles is probably familiar with that. I know Dave is familiar with it. I don't think we have them anymore at the station. So it's a specific type of bandage that you can use, but you can use anything that's elastic to create enough pressure to control bleeding.
We do have them.
You do? Okay.
What's the difference between an Israeli and a hemostatic?
The Israeli bandages don't have a hemostatic agent in them. It's just a pressure bandage.
Okay.
Yep. Hemostatic agents. Ta-da! So this is, it's commonly a dressing that contains a substance that absorbs and traps red blood cells. There are a couple different kinds. Sometimes it can be a powder that you would pour into there, but we actually carry hemostatically impregnated dressing. So you would actually, you see that it looks kind of like that, like a roll, and you're going to do what they're doing in that picture there, and you are going to push it and shove it and stick your fingers down into the crevice and find where it's bleeding from and just pressure, pressure, pressure. And you're going to stuff it in there like you're stuffing a turkey, all right? Down into the hole.
I gotta ask, Chief, then, is that part of current protocols? Because I got my ass handed to me at EMT class when I said you pack the wound. I even taught my kids. We did this whole, we had this whole moulage kit where bleeding wounds, and the kids, I had 8-year-olds packing wounds, and Jeff was adamant. He's like, if you pack a wound, you fail. There's no packing wounds.
So I can answer that one.
Sure.
The simple answer is, which Jeff?
Williams.
Yes, Jeff Williams. Yeah.
So he was answering the question from a MIFRE perspective. MIFRE have a jurisdiction which covers the bricks around the walls of MIFRE. In terms of packing a wound in Maryland, you are not only encouraged to do it, actually it's been modified in the latest protocols that you actually will do it. And you can use tape packing with hemostatics and go in and do a full body wound pack with your fingers. And anybody who says different, they haven't read their protocols.
Understood.
Yeah.
That's also true on the other side of the bridge.
Yeah, I don't think anybody is going to chastise you for stopping and saving somebody's life by packing a wound.
Yes, exactly.
Yeah.
I was going to pack them anyways. I didn't want to piss off. There's no other way to stop bleeding at times. Like if it's a chest wound like that or an open abdominal wound and it's not a complete evisceration, you're not going to stop it by putting a bandage around a rib cage without packing the hole. So that's
absolutely. And there's a great program that Rohan actually just put into the chat box. It's called stopthebleed.org. That's the standard that they're teaching it to now. So if you guys wanted to look at that, you could.
Now, I would add, and I'm sorry to interrupt, Jamie, but I would add one thing. It's absolutely correct that there is hemostatic powder. It does exist. However, it is not approved, and there's a reason for that.
Yeah, well, that's why we use the hemostatic impregnated dressings.
Yeah, that's why we use the hemostatically impregnated dressings, as Jamie said. The reason is because you can create it's a exothermic reaction, and you can actually create burns by packing in deep wounds. So we do not ever use pack.
Yeah, we had an issue with somebody. They had shrapnel in their face, and they wound up like throwing powder all over it because the guy freaked out, and that scarred him up pretty bad, actually.
Ouch.
Yeah. Oh, it's okay. I mean, he survived. So.
That's horrible.
Yeah. But also, I was gonna say, for Stop the Bleed, there's actually a section there also that encourages us to like go out and teach the community, like Mormons or something.
It's But the one thing that you need to keep in mind, though, even though you're packing this wound, manual pressure is always necessary. You can pack all this stuff down in there, and then you stop applying pressure to it. It's not going to do it any good. So you have to maintain your pressure if you're packing a wound like this.
Are we allowed to use a pressure dressing over the packing in the state of Maryland?
Yep. The last one is a tourniquet. We use this if bleeding is uncontrollable via direct pressure. It is only to be used on extremity injury, so you cannot tourniquet a head. Sorry. You know, because of our lovely service men and women, they are usually the guinea pigs here for things like this. You know, testing has shown in the battlefield that tourniquets are useful when bleeding isn't controlled otherwise, and that it doesn't provide any, you know, because we have an average transport time of less than an hour, that there's no real risk to damage to the surrounding tissues, you know, in that time frame. There was a thing a long time ago that, you know, oh, well, don't tourniquet them unless it's necessary because, you know, their arm will fall off or whatever. But we've learned that it's not as severe as they once thought. Once you put a tourniquet on somebody, do not take it off or loosen it. Once it's there, it's there. All right? Just don't do it, because you run the risk. You know, you have this tourniquet, things are starting to clot. Now, if you open that up, now you got a possibility of a clot running right up into their heart or into their lungs or something like that. So we don't want to do that.
We were told the military has actually provided, especially in the special ops community, that you are allowed to, if you can't meet the golden hour, you are allowed to release tourniquets within the first 3 hours. Anything after that, the toxicity of blood could actually kill the individual that you're pushing back through.
That's correct.
But normally, like in certain organizations, we had, like I would go out with a doctor. So we always had a PA high or higher with our team. So, I mean, we just followed his suit. But so I have seen it happen. I just didn't know if that was something we were allowed to do here.
In the state of Maryland, no.
And it really is with transport times. It's, you know, you've got a situation where if somebody's got a very severe distal bleed,
We got a call, we're leaving.
very severe distal bleed from a limb, and they can't be got to a field hospital for several hours, then at that point, that's where you get into that. You can allow some flow so that you don't lose tissue. But the normal time, I think the maximum time for cutting off a limb, when I say cutting off, I'm talking about circulation, is up to 4.5 hours, and you can still recover that limb. So if somebody was going to exceed those times, then I know what you talk about, Wags. You can actually relieve the pressure for a few seconds, just allow that tissue to become oxygenated, and then reseal it. But we don't do that in a non-military environment.
Right. Right. So you have somebody who's bleeding, and I want you to think about it. Is the current method of controlling this bleeding working? You need to move on to a more aggressive step. So look at this guy's finger here. Is that working?
No, not really.
Not really. You see some blood coming through. Okay. I don't recommend tourniqueting the finger. But obviously the little piece of gauze that you tied on his finger isn't working properly. So you may want to add some more gauze. All right. Something like that. Other ways we can stop bleeding. We can splint. We can put cold packs on to constrict the blood vessels. Back in the day, we used to use pneumatic anti-shock garments or mask trousers. We're not allowed to use those anymore. I just think it's a cool thing. They make great abdominal binders. Good for femur fractures. With special bleeding situations, head injuries. Right? This can be from increased intracranial pressure, not direct trauma. Can, you know, stopping those types of bleeds only increases intracranial pressure, so we're not going to mess with those. Right? Some gauze to the outside. Nosebleeds. Have them sit forward, pinch the bridge of their nose. Don't let them lean back. You don't want them to swallow their blood. We're not vampires, okay? If they become unconscious, put the patient in a recovery position and be prepared to suction their airway. That's the big thing with nosebleeds. You want to make sure that the airway does not get compromised.
Do paramedics have anything to deal with a continuous nosebleed?
No, but the hospital does. I learned something a couple of years ago. The hospital carries medical grade cocaine. It's in a drawer in their Pyxis. Like, I was standing next to the nurse and she popped the Pyxis open and I looked down, I'm like, that's like cocaine? Do you actually have cocaine in your Pyxis? She goes, yeah, it's for nosebleeds. I'm like, no shit. Like, you give them a razor blade and $100 bill? I mean, how does this work? No, the nurse actually pours it in there, but it acts as a clotting agent and shrinks the vessel so they don't, bleed out their nose forever. I thought it was cool. I'm like, heck, somebody punched me in the face.
Please don't put that out to the public. We're going to be getting so many
Yeah,
no's.
don't tell Charles County.
Cocaine for the Medicare now.
No.
There goes my clearance.
It's just going to make everybody on the ambulance obnoxious. That's it.
But very happy.
No. But no, we don't have anything different than a BLS thing. Bleeding control is a BLS skill. When you come down to it. So internal bleeding, that's the other type of bleeding. It's the one that we can't really do anything about. When people are bleeding internally, they need a hospital. Okay. You can actually lose your entire quantity of blood into your pelvic region. All right. Severe blood loss can even result from injuries to extremities. So if there's any signs of internal bleeding on a large scale, make sure that we're getting them to the hospital as soon as possible. So you got blunt trauma. This is the leading cause of internal bleeding, can result from falls, motor vehicle accidents, automobile, pedestrian collisions, blast injuries. And you don't even have to be, like in front of the blast where like shrapnel will hit you. You can be 10, 20 feet back, and that air wave, that force can knock you to the ground and cause internal bleeding.
Yeah, the concussion takes, I think it's either 2 or 12 pounds of PSI per square inch of surface area exposed to the blast. Can actually can kill you depending on what part of your body is exposed, but the internal trauma follows up with that.
Okay, phew. I did not know that. See, I learned something new today.
Yeah, well, you got to stay more than 500 meters away from the bomb.
Right.
Yeah, that doesn't always work sometimes. But miraculously, the human body can take an awful lot, because I've had that a couple times and I'm still doing all right. I got a stutter, but other than that.
You had that before we started.
All right.
That's what the VA said.
That's what I told him.
The jury's out.
We also have penetrating trauma that can cause internal as well as external bleeding. So things like gunshot wounds and stab wounds, impaled objects can rupture vessels and arteries, and things inside the body. One of probably the most famous cases of somebody dying due to penetrating trauma, and everybody should know this, is Steve Irwin. Crikey, So he got hit with a stingray barb, and it actually lodged through his chest and pierced his heart. This is why we don't remove impaled objects. Had he left it in place, he probably would have made it back to the hospital and he may have survived. But human instinct, oh my God, there's something sticking out of my chest, let me rip it out. Thus opening the hole in his heart, causing death. So.
It's also why you leave stingrays alone.
And that. Out of all the alligators that man wrestled and poisonous snakes, it was a damn stingray that got him. I mean, really? So signs of internal bleeding. There may be visible injuries to the surface of the body, bruising, swelling, or pain over your vital organs, painful, swollen, or deformed extremities, bleeding from the mouth, rectum, or vagina, tender, rigid, or distended abdomen, vomiting coffee ground or bright red material. All right, so what do we do here? Maintain our ABCs, give them some oxygen, control anything external, and rapid transport to the appropriate medical facility. It's basically all we can do. They need a knife. That's not ours. All right, so with this, because we're talking about bleeding, I want to talk a little bit about shock. I know Andrew went over sepsis, which is a type of shock, a couple weeks ago. I'm going to cover the other ones. So shock is defined as inadequate tissue perfusion. And in the Maryland Medical Protocols, it's listed as hypoperfusion, so low perfusion. And the result of these two things is death, okay? If we don't correct shock, you will die. So for some reason or another, your body doesn't have the ability to supply the cells with the oxygen and the nutrients that it needs. And it doesn't have the ability to get rid of the waste products. And your body just shuts down. All right. So things that can cause shock. A failure of any component of your circulatory system. So if your heart goes down, you're not pumping. If your blood vessels go down, they dilate, they become too large. If you lose blood, okay? Those are the three components of the circulatory system: the pump, the container, and the substance. So we have three different levels. You have compensated, decompensated, and irreversible. So we like to catch people in this compensated range. Their body's shunting the blood where it needs. They're usually still with it. You know, we can get them to the hospital. Go down to decompensated. We're still kind of teetering on the edge here. Blood pressure is starting to fall because the body can't handle that loss of volume for whatever reason, right? If we don't get them help at this point, it's going to hit irreversible, which means your cells are damaged. You're going to die. Once you hit irreversible shock, nobody except for the big guy upstairs can save your life, right? Because your organs have started to fail. So what do we know about shock? First signs that we see: the pulse increases, right, to maintain that cardiac output. Your blood vessels constrict, all right? And when you have constricted blood vessels, you'll see pale, clammy skin. Your respiration rate increases, right? Blood shunting, being shunted away from different areas, that can create nausea, right? Because your gastrointestinal organs are not receiving the blood because it's not considered vital, right? Eventually, you start to see that fall in blood pressure. And then you're going to die. There's no ifs, ands, or buts about that. So hypovolemic or hemorrhagic shock is the first one. Basically, we have a decreased volume of circulating blood and plasma. It can be caused by burns or crush injuries, can be caused by lots of different things. And basically what happens is, we're going to go back to that whole pump container substance thing. So think of a pool pump. All right, so you have a pump that's circulating water through the pool, okay? And it has all the pipes and the big container and things like that. So what happens to your pool pump if your water level drops?
It cavitates.
Yep.
Okay. What happens if you don't fix it?
Burns it up.
Here's out.
Same thing with the body, all right? So we now have this huge wound. We're bleeding out. Our blood level's dropping, which means our container is too big, all right? So the heart's going to start to speed up. It's going to constrict those blood vessels to try and make the container smaller. It's going to speed up to try and circulate the blood, all right? But eventually those blood vessels that are clamped down, they get tired. Your body can't hold a tense position for long. And as those vessels start to relax, the container gets bigger again and everything starts going downhill. So that's your hypovolemic. Cardiogenic shock is another type. You see this in patients suffering from myocardial infarctions. And this is a result of an inadequate perfusion to the heart, decreasing the strength of contractions. Right? Your heart's electrical system may malfunction, the heart beats too slow, heart beats too fast, or it's irregular, any one of those things. And then you have neurogenic shock. And this is the inability to control the dilation of blood vessels because of some sort of nerve system paralysis. All right, there's no real blood loss, but your body can't maintain the right container size because it's not working, okay? You rarely see this in the field. You have to have a really, really bad traumatic injury that damages that nervous system to be able to see this one.
Hey, Chief, can that come from vasodilators? There's a lot of, and this is kind of weird, but like your gym rats, the big dudes that are, they spend a lot of time in the gym, they do some crazy shit with vasodilators. Like they even snort it. It's the dumbest thing in the world, but yeah, it goes up their ass too. So just so you know, you get some weird shit out there with these cats. It's because it hits their system super fast.
Right.
And it's a part of what they call pre-workouts, but it's a vasodilator, so it either constricts or a vasoconstrictor opens them up to allow them. But usually they want to constrict it like coffee. They want to get that. They want to get that quicker hit. Is there something like?
That would be it would be more of like a temporary form of shock. So you may see I've run a couple of calls where guys at the gym, they've done things like this and they've gone passed out
Yes.
because
Yes.
they've
That's
amped
why I
themselves
asked.
up
I've seen this.
whatever it is, and we get there and they're unconscious on the floor. And we sit with them for a couple minutes, give them some fluids to kind of help the situation, and they pop right on back out of it. So it's not like a true shock because it was created by something small that's going to be flushing out of their system. Do you see what I mean?
I do.
And Rohan did put into the chat here. Also, you have to think about your erectile dysfunction drugs like Viagra and stuff like that. That's also a vasodilator that can drop your blood pressure, which is why we have rules on the blood pressure when we give nitro based off of that as well. So signs and symptoms: altered mental status, pale, cool, clammy skin, nausea, vomiting, those vital sign changes. And the mental status change is a result of the decreasing oxygen supply to the brain. So when you see this volume, it shunts blood from all those non-essential areas, and it results in that loss of skin color and temperature, nausea for the same reason, vital signs change as the severity of shock increases. But the first change to see is the respiratory and pulse rates are going to increase. The blood pressure will drop at some point, and then the body cannot keep up after that. So it's an interesting phenomena to watch occur if you're ever in that type of situation. So how do we care for shock? Aggressive airway maintenance. We have to protect that airway. So high concentrated oxygen, attempt to stop the cause of shock. So if they're bleeding, stop the bleed. If they're having a heart attack, fix the heart attack. If we have to defibrillate them, if we have to do CPR, whatever it is, right? Again, this is not something done in Maryland, but it's a national thing. You can use your pneumatic anti-shock garments, right, if you can. But transportation is the most important intervention. Right? Get them to where they need to go, whether that be by ground, by air, by horse and carriage, whatever you got. Get them to where they need to go. We want to splint any suspected bones or joint injuries, prevent the loss of body heat, get them there within the golden hour. I believe it's 3 hours now. Serves me, but and just reassure the patient. Okay. So I think I told you guys about this call a couple of years ago, but for those that weren't witnessing my fun experiences here, I had a guy that I watched go right into decompensated shock before my eyes a few years ago. He got into a fight and he got slashed up pretty bad. So he had a cut that ran from the inside of his armpit down the brachial artery here. He had one down the side of his head and one across his chest. And when we got there, he had about 2 inches of blood in the front seat of the car. There was blood everywhere. And when we got there, his heart rate was in like the 120s. His respiratory rate was up in the 30s. He was still conscious. He was fighting. He didn't want to be there. He was ticked off because somebody just slashed him open, right? And over the course of about 20 minutes, we watched his mental status start to decline. We watched his heart rate continue to increase and his blood pressure start to drop. To the point that when the flight crew got there, the state police officer had to become very aggressive with him to be able to calm him down to get him into the helicopter so they could get him there. And they actually diverted halfway to the hospital. So I'm not sure what the outcome of that was. They were originally going to MedStar and then they diverted to PG. So this guy was not good. And there was no place we could put a tourniquet because of the location of the cut all the way up to here. So it was lots and lots of pressure bandages and fluids. So for the paramedics that are here, why do we want to be cautious about administering too much fluid to your hypovolemic patient?
I'm not a paramedic, but I would say if you're putting too much fluids in it for hypovolemic, you're thinning the blood and you're pushing it out of them quicker. It's not able to coagulate, correct?
Look at you. Ding, ding, ding.
Yeah, that was something that we did in the military. They got really upset that we used to do what's called CLS, Combat Lifesaver, and like the number one damn thing was to stick and give somebody an IV. And then I guess probably within the first 6 months or year of the war, they realized that was the dumbest damn thing in the world because we were bleeding out. We were killing soldiers left and right from bleed outs, and it was just stop the friggin' bleeding, dude. That's the number one thing to do. So that became our priority, and we stopped giving literally like it's like we got to go through IV tech school and all this stuff with you guys just to be IV techs. I mean, I was giving IVs because I was drunk and I was going to PT in the morning. Like everybody knew how to do IVs. Like I had IV bags in my room. So it was a big difference then. So yeah,
Right.
we fixed it.
I used to do, I had a contract in the company I used to work with Janet, where we did some design work for remote monitoring of vital signs in emergency combat situations. It was for Special Operations Command Medical Group. And what was horrifying about that was that we were killing more of our own troops from over administering IV fluids than the enemy were killing, blowing us up by a large factor. I mean, it was like we were ahead like 2 to 1. We were killing more people after the injury than we were from the folks that were trying to actually cause the injury.
So
Big.
Maryland Medical Protocol has its fun little thing here on what it says to do. So like I said, they're calling it hypoperfusion or shock, and this is the new one. So our inclusion criteria, altered mental status, cool clammy skin, diaphoresis, dilated pupils, rapid weak pulse, shallow labored respirations, general weakness, and or decreasing pulse pressures. So for treatments, one, we're going to refer to the general patient care, right, for our BLS stuff. For ALS stuff, or if you're an IV tech, IV IO access with lactated ringers. And then there are specific treatments based on the cause. So if cardiogenic shock, if they have rails, we're going to do fluid boluses. We're going to titrate to a systolic blood pressure of 90 or greater, right? With a max, we have a maximum amount we're allowed to give. Right? We can give an epinephrine infusion. Right? That's something new, right? Or newer. So we're going to put it in a 100 milliliter bag, use that microdrip set, free flowing IV, ideally 20 or gauge or larger. And we're going to check that blood pressure every 5 minutes and look at the mean arterial pressure, or the MAP. For hemorrhagic shock, small boluses of lactated ringers, maximum single bolus of 250 milliliters, okay, to achieve and maintain a blood pressure, a systolic of 90 millimeters mercury or greater. If we suspect head injuries, smaller boluses of lactated ringers to maintain that blood pressure of 110 or greater. If you have hypovolemic or septic shock, if the lungs are clear, we're going to go ahead and give them fluid. Again, we have to maintain titrating to that 90 systolic or higher. Right? If your hypotension is persisting after 2 liters are provided, we want to consider an additional one up to 30 milliliters per kilogram. We can do an epinephrine infusion if that systolic blood pressure remains less. Right. For anaphylactic shock, we're going to give them epinephrine. For neurogenic shock, as far as suspected spinal cord injuries, we can give some fluids, we can give epi. For pediatric patients, right, we all know that kids compensate forever, and then they hit like a brick wall and fall off the side, okay? Kids are scary. So the pediatric patient may present as being hemodynamically unstable or without hypoperfusion evidenced by hypotension and signs such as altered mental status, right? So delayed capillary refill greater than 2 seconds, pallor, and peripheral cyanosis are what we're looking for. Right? Continue your general patient care. We want to get them there as quickly as possible. For them, we're going to give them those lactated ringers. If you have volume sensitive children, we're going to start off a little bit lower. Okay, and we can give up to 3 fluid boluses. And we have a rate there that we have to calculate. So it's 20 milliliters per kilogram. We can also do, for ALS providers, an epinephrine infusion, and this is the dosage that we can do. for initial, if they're less than 10 kilograms, 6 drops a minute. And it goes up from there. So we have some options that we can use to help their blood pressure become a bit more stable. All right, so any questions? Comments, concerns? Guys, that guy's bleeding out the arm.
Once again, James, it's a very good presentation.